I have faith. All right, thank you all for joining. This is our final lecture of the UCSF Global Child Health Lecture Series. So thank you all so much for joining. My name is Teresa Kortz. I'm a pediatric critical care physician at UCSF, and along with Sohel Sood, we are the co-directors of the Pediatric Global Health Scholars Pathway. So thank you so much for those of you who are joining for the first time, and to those of you who have been through the lecture series with us. It's my pleasure today to introduce actually a friend and close collaborator who I've worked with now for years. I'm very excited to see what Dr. Rishi Mediratta will present to us in terms of his primary work and interests. So Rishi is a pediatric hospitalist at Stanford University. He's a clinical assistant professor there, and he's trained at both Johns Hopkins in public health and then went to Stanford for medical school. He's worked broadly throughout the world on many different projects, and today he's going to share with us specifically his work in clinical prediction tools and telesimulation. So with that, Rishi, I'll let you take it away.
Perfect. Thank you. Thank you so much, Teresa. Thank you so much, Sohel, for the opportunity to chat. And I'm glad we're, this lecture series, I think will wrap up today. So really excited to kind of end out the discussion. So today I'm just going to be sharing a little bit about the work that I've been doing in neonatal health in Ethiopia. It's over a culmination of residency and, kind of through COVID and what I'm working on right now. So this is really fun to kind of put everything together. So I would love to make this as interactive as possible. Feel free to put questions in the chat, or feel free to unmute and ask a question during the presentation, and we'll try to save some time at the end. To talk my work, kind of share the work in three main sections. First is I'm going to be talking about neonatal mortality prediction, particularly in a NICU, in two NICUs in Ethiopia. And then we'll think about some of the work in the community. So addressing neonatal health using instructional videos for community health workers. And then lastly, I'll share a project that I'm working on right now to kind of think about telesimulation as it relates to neonatal resuscitation. So just a little bit about myself. I'm from Michigan, and I went to Hopkins, as Teresa was mentioning, and I was interested in public health. And oftentimes people ask me, like, how did you get involved in global health or work in Ethiopia? And for me, it was a little bit of a coincidence. I was a freshman at Hopkins, and I was going home for Thanksgiving, and I had my Hopkins sweatshirt on, and I was in the Detroit, Michigan airport, and someone came up to me and said, "Hey, do you go to Hopkins?" I said, "Yeah, I'm a freshman, thinking about public health." And it turns out the person I was speaking to did his internal medicine residency at Hopkins and had been living and working in Ethiopia for the last 20 years at that time. So we just exchanged contact information, started chatting about health issues in Ethiopia. I had no clue really where Ethiopia was on the map. And we started corresponding about, particularly child health issues and public health issues in Ethiopia. And I got a grant in college to basically hang out with this guy. His name is Dr. Rick Hodes, and working in his clinic. And basically, so I've been working in Ethiopia since sophomore year in college. And every summer in college, I would go to Ethiopia, learn more about the health issues, learn the language in Amharic. And it was such a bummer I have to come back to Baltimore every summer. So basically, I decided, I did this sophomore summer, junior and senior summer. And so I decided, and just kind of thought, what would it look like if I could continue all of the connections, the collaborations that I've been building in the summer for a full year. And so that's why I decided to move to Ethiopia after college. So I took kind of 3 years off between med school and undergrad. The first year really being, in Ethiopia and working on a variety of different projects. There were two main projects I was working on. The first project was I was starting a community-based and education and health program for 91 orphans in Gondar, or just a little bit north of Gondar, called in a city called Tadda in northwest Ethiopia. And basically the idea was that these children were often orphaned because their parents had HIV and died from AIDS, and they were living with grandparents. And we were trying to focus on health and education. So really it's, providing educational tool like uniforms and pencils and notebooks, but also consider what the health and community health needs are in the community. And so we decided to run a community health kind of adolescent peer health education about reproductive health issues using coffee ceremonies. And so in the top right, there's a picture of a traditional coffee ceremony. And coffee ceremonies it's a very culturally sensitive way to bring information in and elicit information in a community. If you have a guest, you would often have a coffee ceremony. And so it was an opportunity to come to meld a culturally appropriate concept and tradition with a health education mechanism. And so now this program is kind of taken over by the local kind of community in Tadda. And then the second project I was working on was thinking about community health interventions, particularly about the Integrated Maternal and Neonatal Child Health Program, or the IMCI program, and really thinking about what the communities practice about and their knowledge about child health promoting behavior. So I loved, I think, the opportunity to kind of spend some time in Ethiopia, live there, build more connections, really set me up kind of with the collaborations that I've continued to have over the years. And I studied in London after living in Ethiopia. I studied medical anthropology at the School of Oriental and African Studies, and then public health at the London School of Hygiene and Tropical Medicine. And then I've been at Stanford ever since. Teresa asked me to share a little bit about where I work. And so I think it's helpful to kind of think about, I'm predominantly a pediatric hospitalist. I spend 60 to 70% of my time clinically, and I'm rotating through 4 main hospitals. I'll start in the South, and every hospital has a little bit different spin in terms of the clinical responsibility. So in Watsonville, we have basically, it's a community hospital, predominantly neonatal, well baby, and emergency room consults. We have some pediatric beds there, although it can be a few patients, but a lot of going to well babies. It's predominantly a Spanish speaking or Mixteco speaking community, and it's a true community hospital feel. I'm the only pediatrician, or there's one pediatrician per 24 hours. And so that's kind of part of the more neonatal work. A little bit north in Mountain View, I work in El Camino Hospital. We have a pediatric floor, which is kind of split between an eating disorder unit and then a general pediatrics admission. And then we also have some neonatal coverage with the well baby unit in El Camino. And then at Packard, I work often overnight, supervising the pediatric residents. And then I also help with the providing sedation in radiology, which is the nice thing is it's during the day. So I have some daytime coverage where basically providing minimal moderate sedation for children needing MRIs and other radiology scans. And then in San Francisco at CPMC, we have another community hospital where I work at. It has a lot more pediatric subspecialists, and so a lot more surgical kind of co-management. And so I really like the range of duties that I'm able to do kind of clinically. But I feel like I have 2 jobs. One is the clinical work, and then the other work has been in global health. And so I'm excited to share a lot of the work in global health. And so I'll first start with the work in neonatal mortality prediction in the NICU. So this is a picture of Dr. Martha, who is a second-year pediatrics resident, and we're in the NICU at the University of Gondar in Ethiopia. And so I'm just curious. I think Teresa had mentioned there was a few second-year residents. So how many second-year residents or PGY2s on this call would feel comfortable and confident leading rounds in a NICU? I see Matt, you're a second-year pediatrics resident. I know, and I was a second-year pediatrics resident at this time, and I thought it was pretty impressive that Dr. Martha was leading rounds and the attending basically didn't show up. So this is sometimes a common scenario where pediatrics residents are in charge of teaching, they're in charge of clinical care, and there's so much admiration and respect that I have for my colleagues, my residents in Ethiopia, where they work under challenging situations. They don't have access to the clinical diagnostic tests that we have, and they're really, providing quality care with, with the limited resources that they have, and I think they're doing a phenomenal job at that. So I think it's helpful to kind of think about, where your skills are and where other individuals are globally, and is there an opportunity to kind of collaborate and understand each other's perspectives. So my journey in neonatal health started in a morning report in Gondar. I was a medical student. I spent a summer, rotating at the University of Gondar Hospital, and we would have morning reports, just like we have morning reports at Stanford or UCSF, where we talk about educational ideas. In Gondar, many of the morning reports would start with the clinical cases the previous night, and particularly challenging cases or children or neonates who had died. And so over the month, I was struck by how much we were talking about neonates who had died the previous night in the hospital, and this kept on happening. So I was certainly interested in why was that happening, and why, what could we do to kind of identify and prevent some of that preventable neonatal deaths. So I learned and started to learn more about neonatal health in Ethiopia, where globally there's 5 million children dying before 5, and half of these are in neonates, almost 2.4 million neonatal deaths. And then among these neonatal deaths, half of them are really concentrated in 5 countries: India, Pakistan, Nigeria, DRC, and Ethiopia, having 3% of the global burden. So to me, Ethiopia made sense in terms of there's a clear need, from a global perspective, but also what I was hearing, at the University of Gondar, and most importantly, my collaborators, my friends, my colleagues at the University of Gondar were interested and motivated to address this issue. And so we basically set on this journey to kind of understand a little bit more about the NICU care, and can we design an early warning score to identify high-risk neonates in neonatal intensive care units, NICUs in Ethiopia. And so often these early warning scores, exist in our settings. There are many tools or scores that often rely on laboratory parameters, or they rely on clinical parameters about whether you're intubated or not. However, many of those current scores are not relevant because we don't have the, you can't intubate a neonate at Gondar. And often the babies are not getting labs very frequently, like lactate often, which is a common measure in many of the current scores. And so the idea was, can we design an early warning score to identify these sick neonates upon admission to a NICU and to kind of risk stratify? And so that's kind of the first theme that I was have been thinking about. So this hypothesis was that we can, an early warning score can be created to predict neonatal mortality upon admission based on clinical variables in one NICU in Ethiopia. So what I started was the first of the 2 case control studies on this topic. So we did a retrospective case control study recruiting neonates at the University of Gondar NICU. Cases were those who were defined as neonates who died, and controls were neonates who survived. And we had a kind of 2 data sets from 2 different years. We had a derivation data set where I had 812 total neonates. And then I came back, this was when I was a 3rd-year resident, where I kind of came back into this 3rd-year resident to kind of collect the validation data set, where we got a 246 total neonates. So one of I want to impart, a little bit about the context about what's going on in Gondar's NICU. So the University of Gondar is one of the main teaching hospitals in the Amhara region, kind of serves 7 million people as a population. In the NICU, there are around 40 beds, and they are increasing. And it's predominantly staffed by 6th-year medical students, pediatric residents, and general practitioners. And that's really important because most of the interns, or an intern is a 6th-year medical student in Ethiopia, they do not have the clinical skills to identify who is sick and who is not. They're learning that, and I think that's even as an pediatric intern, that's an important lesson, is to kind of figure out who is sick and who is not. But then within that, understanding who is a sick neonate and who is a well neonate is also a little bit challenging. So most of the care is provided by healthcare providers that may not know the subtleties and the nuances about, who is sick and who is not. So there's certainly a need to understand, to help frontline providers identify sick neonates versus, individuals or neonates that, may not need NICU level care. And for context, there was around a 14% NICU mortality rate in the Gondar NICU, which, is pretty good. There's certainly been other settings which it has been much higher. And I know the NICU and Gondar has really worked on that, and there's still room for improvement there. So what we did, so this kind of pictorial representation of the methods, we started with understanding the admission variables that these neonates had. So we looked at the birth data, so their weight, their gestational age. We looked at the prenatal or delivery data, and then we also looked at the admission vital signs in their exam, and to kind of understand what variables would be relevant to predict neonatal mortality. So we first started with a univariate prediction logistic regression, and then we identified 11 variables that were significant, at least at the less than 0.05 level, entered them into a multivariate logistic regression. And then 4 variables came to the top as having a prediction in the multivariate model. And then the idea was to kind of figure out, can we develop a score from these variables? I think I think it's important to understand, like, how do you create and do high quality research in a setting where most of the data is in paper charts. And so this is probably a typical scenario in many low and middle income country chart rooms, where you have there's a clear method to the madness here. There's an organization, and you have to basically, pull the paper charts. And so what we would do is, so my colleague on the left, Dr. Ashinafi, who was a close friend and collaborator, would identify the neonates based on the registry, would go to, there are often women in the chart room, and we would kindly request, the charts. They would pull the charts, and then we would spend, Dr. Ashinafi would, abstract the data, and his girlfriend, now wife at the time, Dr. Eleni, would help us. So this was it's a family-based collaboration. And so we would collect this data looking at the charts on REDCap. And so part of what we realized is that the internet was not reliable. So it's not that we can clearly extract this data and send it online. So we had to kind of use REDCap and the offline function on tablets, in which I brought over, and we had to collect some data. And then here, so Dr. Abdul Qadir and Dr. Mulu we're on the 3rd floor of a building of one of their apartments, which has one of the better internet signals that day. And so we were just kind of waiting for the data to upload. And there's certainly some, growing pains in that we had some data kind of lost in this when we realized if we were syncing all the data from the tablets at once, that REDCap really doesn't like that. And so, we learned from that, but you can collect data offline and collect data from paper charts to kind of understand and organize the neonatal population in a particular registry. And so that's kind of how we got the data. So first, I'll just share a little bit about the data. So this is the first table, which is on the univariate analysis. And so we have cases here first, 207 cases, controls 605, the odds ratio, the confidence interval, and the p-value. So I'll just kind of point to some of the variables that are coming up on this univariate analysis. So gestational age was, and the outcome is neonatal mortality. So gestational age being important, birth weight being important, information about suctioned at delivery or bag mask at delivery, or if they were intubated, CPAP on admission, and then clinical characteristics having the admission heart rate either too low or too high, admission respiratory distress, having a low respiratory rate, and then admission temperature, being cold, hypothermic. The admission respiratory distress, so the more, respiratory distress, kind of mild, moderate, severe, and kind of define that, associated with mortality. And then the level of consciousness, whether, you're irritable, lethargic, or comatose, that's going to be more associated with mortality. And so we put the variables that were significant into a multivariate analysis. And so, there are 4 key variables that are coming up to the top. So the first being admission level of consciousness, the second being the admission respiratory distress, the third being the gestational age, and then the fourth being the birth weight. And so you can see here, the odds ratios, the variables with that are quite strong, we are the admission level of consciousness or the admission respiratory distress. If you're in severe respiratory distress, grunting, flaring, retracting, and some cyanosis, you're going to be severe. And then the prematurity, of course, and low birth weight being kind of also important variables. So what we did was, this was kind of the multivariate analysis, and then we said, can we create a score where it's easy, you can assign an integer to these variables and create a score. And so that's what this score on the right-hand column represents. So basically, this is what the neonatal mortality score is, which is a score from 0 to 52. The variables, or the variables with the higher odds ratio have a higher score, so it's more or less weighted. And so basically, there's kind of 2 ideas here. One is the multivariate analysis, which has the coefficients that are, that have some decimal places that you need to kind of have, you have to plug them into a quadratic equation. So it's not easy to kind of implement on the bedside. And then we also have the neonatal mortality score, which we're kind of trying to figure out, could this score be useful? And so, when you're trying to validate a model, there's kind of 2 components. First is thinking about the discrimination of the model. So what is the area under the curve with respect to the multivariate analysis and then the neonatal mortality score? So the first basically the idea, the take-home point is that both the multivariate model and the neonatal mortality score have really good discrimination in the derivation data set, and then using a different data set where the data was not defined, the validation data set. So here is the derivation data set on the multivariate model, and then here is the neonatal mortality score, and both having area under the curve of 0.88. And then when we apply these variables to a new data set, and the validation ones, again, a little bit lower discrimination, 0.85, but very similar between the multivariate and the neonatal mortality score. And so that tells us about the discrimination of the particular model. And then we also want to think about calibration. So the calibration was still pretty good. So calibration is basically looking at what is the expected probability of what happens, death or survival, and then exactly what actually happened. And so it's based on the probabilities. And so, certainly room for improvement on the calibration, but it still was pretty good. And so overall summary here was that, the neonatal mortality score is composed of 4 variables: birth weight, gestational age, respiratory distress, and level of consciousness. And it has a similar discrimination and calibration as the multivariate model, and it has an excellent discrimination and calibration. So it basically, these are variables that do not require a calculator. You don't need to, you need a scale. The gestational age is calculated after the baby is born, because oftentimes the last menstrual period and ultrasounds are not available, and so there are scoring methods to identify the gestational age. But it's really looking at the baby, looking at the weight, you can identify pretty quickly who is sick and who is not. And then this is what the score would look like. So that's kind of out of 52, and on the y-axis here is the probability of mortality. And so a 50% probability is this kind of arbitrarily defined from a statistical perspective, corresponds to a score of 12. And so there's definitely opportunities to calibrate and tailor the score to a particular setting. So for example, if an institution is interested in identifying, if an institution has the resources to identify and act on high-risk babies, then they could change the cut point. Or let's say, for example, an institution does not have the resources to respond to a higher score, then maybe you'd want to increase the probability of mortality, choose a higher cut point to actually respond to the risk score. And so there's certainly an opportunity to tailor the score based on a clinical setting. So that was the first kind of foray into kind of identifying the neonatal mortality score. But you have to remember, the derivation validation data sets were in one hospital at the University of Gondar Hospital. So the next hypothesis was I can create an early warning score to predict neonatal mortality in another NICU, in another hospital. And so this is really getting at the external validation at a different hospital. And we also interested in understanding if we could, break down the groups, the categorical groups for birth weight and gestational age, and to kind of consider maybe if we have more groups, it may produce a stronger model. So that's when I approached some other colleagues at St. Paul's Hospital Millennium Medical College in Addis Ababa, in the capital of Ethiopia. It's one of the two largest hospitals and NICUs in Ethiopia. I think I was just there last month, and they have about 70 neonates, 60 to 70 neonates at any given day. So here, this was a similar, again, retrospective case control study looking at 406 cases or deaths and around 2,267 controls. So the sample size was better, and so that's why I think the having enough power to make some of these calculations is important. So I had one of my pediatrics residents, Maggie, work with me to analyze this data. And so we basically ran the same analysis in a new hospital to kind of understand, are the same variables coming to the top? And, consistent with the previous model in Gondar, we found that gestational age, respiratory distress status, and level of consciousness were associated with neonatal mortality, but birth weight was not. And then Maggie created a score, using slightly different methods, but it's from 0 to 23 to figure out, can you calculate this at the bedside? So the benefit of this score would be you have 3 variables: gestational age, respiratory distress, and level of consciousness. And the score, holds up pretty well in terms of the derivation and, in terms of the discrimination and the calibration, the area under the curve of 0.885 or 0.89. So similarly, it's a pretty good discrimination. So, now the next question is kind of like, okay, so what? The score is only as good as an implementation. So the next phase of this project is thinking about implementing this prospectively. So step 1 would be enrolling local hospitals and training nurses and providers on using the score, identifying all babies to a particular NICU and scoring them, and then identifying the high scoring neonates and providing a bundled set of intervention that could be, focused on not only the intervention, but also the communication, because there's often a lot of gaps in information about babies or about children being escalated from, a pediatrics resident or general practitioner to the attending. And then, measuring the outcomes and identifying areas of improvement certainly is part of it. And so, this is the next phase that I'm, actively working on is, can we identify neonates upon a NICU admission who are at high risk prospectively? And then could we implement a bundled set of interventions to identify kind of high risk neonates with the hopes of reducing neonatal mortality? So I had a med student working with me in the summer identify kind of a mock-up of what the tool would look like. And so he took basically the neonatal mortality score that we had from Gondar and just created it into kind of a paper copy where we identify the main variables. We have the different parameters and the score. And then basically, if the score is greater than 12, then we would start, within the first hour, a set of interventions, which may include starting oxygen or CPAP, checking the sugar, starting dextrose, addressing the hypothermia, inserting an IV, obtaining labs and a blood culture, starting antibiotics, and then identifying the baby as, higher risk, and then calling the senior resident or the senior consultant, and then, considering for babies with HIE to watch for and treat for seizures. And so this still needs to be determined, but I think that we have some ideas that we can at least identify retrospectively clinical parameters. And I think it's going to be more exciting to kind of think about, what can we do prospectively when a lot of these hospitals have many children, and they are understaffed, but still there could be a need to kind of help equip frontline providers. So that's the first kind of project that I've been working on, is really working about neonatal mortality in the NICU. I want to transition to thinking in the community. And so, whenever I think about neonatal health, I think about what's going on in a tertiary care institution, but also what's happening in the community. And I would argue, half of the deaths are happening in a community setting. And so they may not even reach a hospital environment, whether it's a health center, primary, secondary, or health post level. And so what can we do to equip our community health workers to understand the signs and symptoms about neonatal health? And so this is a picture from a instructional video curriculum that we had created that I'll tell you a little bit more about in Gondar. So basically, this project, there's a gap in the literature about how to effectively deliver health education in order to improve community health workers' competency to recognize neonatal danger signs. And we really need to think about new platforms, develop them, evaluate them, particularly for community health workers about neonatal health, because often many health workers don't feel confident providing information about a neonate or even referring individuals based on the clinical condition. So what we decided was we would create a curriculum using videos about neonatal health that were already created by the Global Health Media Project. And I think that group is a tremendous resource of videos across a variety of different topics, and they've even translated them. I think they're very well done. So basically, I reached out to one of the contacts there, Peter, and he was happy and willing to have us use their content in a kind of a curriculum. So we recruited urban community health workers that were employed by John Snow Incorporated's program at Gondar for the project. And basically, we had a 2-day educational intervention where we showed videos by the Global Health Media Project. And so I identified these videos and put them into a few groups. There are 5 main categories about videos. The videos are about maintaining body temperature in a newborn, identifying danger signs, what to do during home visits, cord care, and then caring for low birth weight babies. So each one of these bullets represents a module of video that that the Global Health Media Project had produced and gave us permission to run in a course. And so the objective was really to understand, assessing knowledge. Like, let's start with knowledge is to kind of see where the community health workers are at. So we created a 45-point multiple choice question, assessing community health workers' knowledge about neonatal health across the 5 different general modules and topics that the curriculum was focusing. And I think we did a pre and post test, which is fine, but I think what's most important is what's happening later. So we did a 6-month final test to assess the knowledge amongst providers. And we had 67 community health workers participate in the pre and post test, and then 42 of them participated in the 6-month final test. And the health workers watched 17 videos over 2 days. The mean pre-test score is at 64%. The mean post-test score is 80%. And then the 6-month final test score was 71%. So it kind of goes up and then it comes back down. And the immediately post-test and the 6-month test is significant when you're just looking at paired t-test. So this is the same data, just graphically, thinking about, what the score is pre, post, and then 6 months later. So still 6 months later, these community health workers are still retaining some knowledge about neonatal health, after watching a set of videos in an educational session. And then kind of breaking down across the 5 different topics, what health workers are thinking about and what proportion they're getting correct within those particular questions. So, most of them are getting, doing much better in the modules about the questions about temperature, about home visits, umbilical cord care, and care for the small baby, and not as, there's not a significant difference on the danger signs, which likely requires a little bit, nuanced medical understanding, which I think we're, slowly moving the ball. So community health workers retained neonatal health knowledge 6 months after watching the videos, and these videos may provide a platform to scale large community health worker programs globally. And so I think we need a little bit more research to understand how to improve neonatal knowledge, but also correlate the knowledge with outcomes, because that's what's the most important thing. So we did this study, and the same presentation that I'm giving you, I gave to the child health cluster team within the Ethiopian Ministry of Health. And I just said, look, this is data from your country. And I think they were particularly struck by that. So after a discussion, they selected 2 videos from the Global Health Media Project to be included in the Health Extension Worker Refresher Training Program for Ethiopia, reaching over 40,000 community health workers. So it's a nice lesson on using data to influence some policymaking decisions. And I think having the data come from Ethiopia's health workers, I think, made it a stronger sell when a lot of the officials were considering whether to adopt this curriculum or not. And so I think that I'm really happy about that. So this project got me interested in the use of videos or other technology. And so I will share a non-neonatal but pediatrics topic or curriculum that I'm actively working on. And so that is a pediatric respiratory distress curriculum. And I actually have a video that I'll show you. It's a 3.5-minute video. But basically the idea is, can we use videos, instructional videos about identifying signs and symptoms of pediatric respiratory distress? And can we share that with providers, here at Stanford, at UCSF, or even globally in Ethiopia? And so I think there's a lot of variation in knowledge. And so I'm working with a team of undergraduate pre-med students who have interesting and really good video editing skills. And then I'm helping source the content from, WHO, IMCI program, YouTube, TikTok, and we're able to kind of identify videos about identification of respiratory distress. And I'll just play one of the videos here just to kind of give you a sample of what we're thinking about.
Grunting. In this module, you will learn to identify grunting, which is a worrisome sound that children make when they attempt to prevent their airways from collapsing. The first objective is to understand the physiology behind grunting. The second objective is to identify grunting in pediatric patients with respiratory distress. Grunting is the result of a child's attempt to prevent their airways from collapsing completely at the end of the breath. Grunting mechanistically occurs due to exhalation against a partially closed glottis. Note that the glottis is an opening between the vocal folds where air enters the trachea. This is also known as the windpipe. Now let's look at how grunting occurs. First, the glottis is closed. Then, Expiration against the closed airway causes an increased positive end expiratory pressure, which is known as autopeep. This allows the child to keep its alveoli open for a longer time and prevent the lungs from collapsing. Then, the glottis is opened and the rapid exhalation of air makes the grunt sound. Grunting is a sign of moderate to severe respiratory distress in children with lower airway disease, such as pneumonia, atelectasis, and pulmonary edema. Here is a clip of what the alveoli and airways look like when we breathe normally. Notice how the airways and alveoli are open at the end of expiration. Here is a clip of what the alveoli and airways look like when there is lower airway disease, such as pneumonia. Notice how during inspiration, or when we breathe, the alveoli open, but during expiration, or when we breathe out, the alveoli collapse. This means that there is low pressure at the end of expiration. In response, the child generates increased pressure in order to compensate for the collapsed alveoli at the end of expiration, resulting in grunting sounds. These sounds are heard when the child breathes out. Now let's take a look at what grunting looks and sounds like in a few children. So the main takeaway is that grunting is a sign that the patient is experiencing collapsed airways due to lower airway disease and is generating pressure to keep them open, which is a sign of distress.
Great. So just an example of what we're trying to develop and continue this theme about using instructional videos, which I think has a lot of different potential. So the last part that I'll talk about is the role of telesimulation in neonatal resuscitation, and this is in particular reference to a curriculum called Helping Babies Breathe. And so HBB is a curriculum to help frontline providers resuscitate a newborn who is not crying at birth. The AAP developed this, and over the last 2 years, particularly during COVID, we were thinking about as in-person training activities were canceled, there was still a need to implement and train frontline providers, and so we understood that a lot of the providers were interested in using and simulation as a way to practice and think about keeping their skills active. And so telesimulation is one of those methodologies where learners are helping develop their cognitive, kinesthetic, psychomotor skills, real-time, hands-on, basically facilitated over Zoom or an online methodology. And then it's been used in a lot of different topics in medicine, but not necessarily as much in the Helping Babies Breathe curriculum or in neonatal health. So there's a group at Stanford called Go Moms, which is basically a group of obstetricians who have been doing simulation work on OB care, particularly from a group of midwives in Tijuana across the border. So Go Moms was basically put in place to kind of teach simulation about OB topics, and the midwives in Tijuana requested help in their neonatal resuscitation and their neonatal outcomes, because often a few of these neonates had poor outcomes, there were some deaths, and so we were kind of welcomed into that community. And so we basically added some pediatricians to that And we've been teaching online via Zoom with the addition of a neonatally live mannequin, which we shipped to the midwives before the training. And so we're able to do this training over Zoom. And so I think this training helped us understand that really can provide teaching about, how to hold a bag mass, which requires a lot of, hands-on training over Zoom. And so here I was going through the flow sheet over Zoom with these midwives on helping babies breathe, at least the algorithm. We had, topics in English and Spanish, and then the midwives, have the bag mask or have the neonatally live there, and they're able to practice and we're able to kind of give feedback, and you're able to kind of see chest rise really even in Zoom. And so I think it's an opportunity to scale up and use telesimulation in a way that could help promote neonatal resuscitation skills. So we know that, helping babies breathe training improves immediate knowledge and resuscitation skills. HVB has been shown to decrease perinatal mortality, intrapartum related skill deaths, and neonatal mortality in the first 7 days of life. But these knowledge and skills will decline over time. And, we know that virtual training has been effective to immediately improve knowledge about COVID and resuscitation in adults. And that an online HVB course was as effective as an in-person format about increasing the efficacy of a small group of pediatric residents in the US about neonatal resuscitation, but really don't know how to sustain the skills and knowledge for neonatal resuscitation, the right way to deliver this content, and how virtual training influences knowledge and skills, and if a telesimulation delivered kind of curriculum would be as good as an in-person curriculum for increasing providers' knowledge and skills about neonatal resuscitation in a setting, in a low-income country setting. So that's what the hypothesis for the project that I've been working on right now, which is a telesimulation delivery of helping babies breathe. And I think it's going to be as good as in-person delivery with regards to participants' proficiency and resuscitation skills. So this is a non-inferiority randomized control trial by pediatricians who are HCV certified in Ethiopia. We can have two groups, an in-person training over 1 day and then another day with a telesimulation. And we're targeting clinical nursing students, midwifery students, and medical students at Jimma University. So we, with respect to the study group, we have, the telesimulation, the control group. Before the course starts, we'll give them a knowledge test, which has been validated, and assess their attitudes about neonatal simulation. And then right after the course, we'll give the knowledge test again, reassess their attitudes. Think about, there's an HVB bag mass checklist and an OSCE where we're able to ask them to kind of run through a scenario, and those are going to be, both in person. And then we have mannequins that are high fidelity mannequins called the Neonatally Live, and we can actually get you can change the lung compliance. You can make it harder to resuscitate or to open the chest, to open the airways. And so you can, add a little varying kind of complexity to the simulation to kind of see how the participants will perform. And the cool thing about neonatally is that we're able to kind of collect data about, the pressure that the participant is using to open the airway, the frequency of breaths, so the ventilation rate, and how successful were they in a head tilt. So that's some cool data that I'm looking forward to collecting. And then we'll do a similar follow-up study in 2 months, looking at the similar parameters, and then we'll add a qualitative component, looking at we'll add a focus group discussion, thinking about how the particular group liked or did not like the telesimulation or the in-person training. So one of the challenge with setting this program up, it was delivering 40 mannequins to Jimma University. So I had to go to Ethiopia last month, really had 4 bags of these mannequins, partly because I wasn't able to get an agreement or an MOU between Stanford and Jimma University in place. Often that can take a year or longer. And so through a lot of different kind of mechanisms, asking for help, we found that the best methodology was to actually bring it in checked luggage and then get permission letters or donation letters from my colleagues to kind of make sure that we, are bringing them in. And so I was able to kind of bring that into the the program at Jimma University. But it's certainly, challenging to kind of deliver equipment that collaborators need, and I'm learning as I go there. The last thing I wanted to impart was, doing global health research requires patience. I think that's something that my patience has definitely been tested, at least working on this HBB project. IRB delays, which are 2 to 4 months, which are pretty standard, and I think that's even short. Sometimes I've seen up to 6 months. And then I've learned that, getting access to funds that have been awarded requires extensive setup and approval through your department in the Office of Sponsored Research, and it's hard to kind of navigate who is responsible. And often it's not the most efficient method to kind of even get access to the funds. Learning about hard to ship equipment into a country that you have to think about customs, you have to think about agreements and what's feasible, and you'll have to come up with alternative mechanisms. I've been learning about the different ways of paying colleagues, and often they require some agreements between both universities and a subaward, which requires collaborators to submit a lot of financial audits, a lot of IRS information, so that process can take time. I think one thing I'm struck by is institutional approval for documents for collaborators is often not delegated. I'm surprised that the documents that we need to set these collaborative research agreements or subaward processes are signed by a president of university, and they just don't get delegated. So it takes longer. Often that individual may not be around, and so you have to it's a lot of waiting week by week to see what happens. And then of course the internet is unreliable, so we need some offline data collection options, and I think surprisingly there's a lot of really strong options that are available. Lastly, just a lot of collaborators over the years, particularly at the University of Gondar, Dr. Ashinafi Tazibo, Alamayo, Abdul Kadir, and Mulugeta. And then, collaborators at Stanford, Saraswati Kache, Rasika Bal at Maggie Gabra, and then some neonatal help and OB help, Henry Lee and Kay Daniels. I've really appreciated working with the Department of Biomedical Data Science at Stanford. Brad Efron he basically invented bootstrapping, which I didn't show that data with for our neonatal mortality score, but he certainly helped us along with NARIS. John Snow Hibrit helped us with recruiting health workers for our instructional videos neonatal health program. Peter Cardalicio at the Global Health Media Project, and then more recent collaborators at Jimma, Dr. Mokamu and Dr. Lulu, helping kind of move our current project forward. And very grateful for kind of the variety of sources of funding that I've received for the neonatal mortality score, for work through kind of the instructional videos program for neonatal health, and then more recently on Helping Babies Breathe project. And with that, I would just like to end, for the residents or medical students in the audience, I'm happy to connect, and University of Gondar is welcoming residents and medical students. So feel free to, email or text or call if you're interested in, learning more about neonatal and child health in Ethiopia. Thank you so much for this opportunity.
Thank you so much, Rishi. That was amazing. There's a few other people who have presented at this lecture series who I'll see if you've been connected with them before, who do similar work, but really amazing to hear all the stuff that you've done since training onwards. Quick note before we open it up to questions, there is a link in the chat. Thank you, Tiffany, for our eval. It's a very short evaluation, a couple of questions. We do really appreciate your input. If you could just take a minute to do that. And then I'll open the floor to questions. I can start things off. Rishi, one of the kind of themes that we've had throughout this lecture series is kind of the bidirectional nature of the work that we do. And you kind of alluded to this, but what do you see in terms of what you've implemented from the risk scoring and prediction modeling to the app development? What can we kind of learn from the work that we've implemented in other settings and actually implement that in our local Bay Area settings and beyond?
Yeah, I think, the role of collaboration is so critical, particularly, projects come from my collaborators in Ethiopia. And I think, that's just a key part of, sustainability for projects. And I think, there's a lot of the work that particularly the neonatal, the respiratory distress curriculum can be implemented here, in the US, particularly for our group. So I think, I think there's lots of opportunities that my collaborators have learned, and basically we have lessons that we can learn from how collaborators in Gondar are implementing projects, and so I think there's certainly a lot of opportunities that I've seen, but it always comes down to the people and the collaborators at, in my case, in Gondar, in Ethiopia, and having those relationships sets the foundation for, current project and feedback. I think what I've learned is that, important, feedback is critical in order to kind of create that space where we have constructive feedback. It's important to have those relationships in place, and that will, I think, allow for thoughtful projects that reach the audience that they're intended for.
Yeah, thank you, Rishi. You covered a lot of territory. Really appreciative. And I was thinking very similarly to Teresa that the themes of app development and technology have been consistent throughout the past few weeks of this series. So certainly want to make sure we can facilitate any connections on those topics. And on those themes, I actually want to loop in a few folks from our audience into this conversation. So maybe my first question is to the interns on the call. A lot of your medical school experience because of COVID became virtual, right, to some degree. And I'm curious if what Rishi's mentioning about virtual education is analogous to the ways you were taught, in your parts of your medical school training. So I'll ask that question first, and then maybe after that, Fritz, who's joining us from Boston, but has strong connections in Haiti. Curious also if there have been some facilitations of some virtual educations in that space as well. So maybe to the interns first.
So I can say that, yes, during my medical school training, I wasn't really affected by kind of the virtual environment. I think by the time COVID hit, I was more kind of into my clinical, or I guess by the time I got back to my medical school training, it was more in the clinical setting. So the virtual learning environment really wasn't a huge factor. I did do business school during like the deepest parts of the pandemic. So all of that was virtual. A lot of it was difficult. I guess that would be the best way to say it. It was uncharted territory for all the professors, and it was just a learning environment that was very new. But I suppose that, given the constraints, it was the best that we could do at the time. So I would say that, virtual teaching is never ideal, and it's usually a product of constraints for whatever environment that you're in, which speaks to your experiences as well. So I do think that there's definitely a time and a place for it, as we've learned throughout the pandemic. But if it does tend to have a lot of drawbacks that you wouldn't get in kind of that in-person setting.
Thanks, Ted. Yeah, go ahead, Fritz.
Hello, do you hear me? Hello?
Yeah, we can hear you. Yeah.
Yeah, so I'm late for this conference today. Sorry, I didn't catch I came at the end. I understand that it's something related to virtual presentation. In Haiti, we didn't have so many problems because, you know, COVID didn't have this huge effects in Haiti. I'm currently in the United States, in Connecticut. So I think as I talk with friends and colleagues in Haiti, the students, interns, and residents, they go in person more. We didn't have this huge pandemic in Haiti. So they did with mask and keeping distance, but there was no such a problem. I think in hospitals and residency, everything goes well, and there's not huge problem with internet or such a thing.
Yeah, thanks for sharing, Fritz. Just for context for you, in the United States, a lot of medical schools would, and Sunny, maybe I'll call on you next, they would basically stop the medical students from going into the hospitals at parts of the pandemic, and saying that the hospitals were too dangerous, we're still learning about COVID, only those who are directly providing supervisor level care were the ones performing clinical service at certain points. And so training just took on a very different shape during that time period. And Sunny, what was that like for you? Oh, you're on mute. Sorry.
So sorry. COVID started, I think, we had a dedicated period where we could study step 1. And then I think COVID hit, like just started when I was like finishing up my step 1 studying. So we actually delayed our clerkship, I think for 2 months. So we were supposed to go start working at the hospital in April, but we, I think, ended up starting around June or July. So like for those 2 months, like I didn't really do much. Yes, we had like a virtual like didactics and lecture series, but I think I just want to like echo what Ted says. I think I personally feel like in-person experiences are the most ideal, but I think it was really helpful to have those like lectures and didactics on Zoom or virtually that kind of helped me prepare. And I love the fact that like all those like virtual learnings, you can always go back. So I think for me on one of like internal medicine rotation, like I remember seeing that from one of our didactic series. So I was able to go back and kind of review. So yes, it's not the most ideal, but I think it definitely has a place to be really useful.
Yeah, I definitely agree with that. Like, you know, a lot of some of the work, particularly in humanitarian crises and disasters, is where we need a lot of the more help with respect to, you know, mortality reduction or morbidity reduction. And so, as Ted was mentioning, that's where there's a lot more, you know, constrained resources. And so I think, yeah, there is an opportunity to kind of address an educational demand, you know, in areas where, you know, the resources are not, you know, meeting the supply or meeting the needs. And so I think there's, you know, it depends on, you know, what the resources that are available or how you're influenced by COVID. But I think still there's, you know, even with COVID or not, there's areas where there's still likely be a need, probably unlike the need where, and you know, need where there's, you know, there's a lot of other challenges, you know, politically, culturally. And so, you know, I'm hoping to kind of, you know, show that maybe in the future.
Well, thank you so much, Rishi, and thanks to everyone who participated in the lecture series. Really appreciate it. And thanks for making it a success. And for those in the area, hope to see you in person this afternoon. All right. Thank you all.
Thank you.
Take care.